Welcome to today's Explainer. We're diving straight into a rapidly unfolding global health crisis, one that's currently triggering the absolute highest alarms at the World Health Organization. Right now, there's a highly serious situation developing in the Democratic Republic of Congo and neighboring Uganda. And listen, this isn't just your standard, localized health scare. The dynamics of this specific outbreak are literally shifting the ground under global health authorities, and the implications? Well, they stretch way beyond the borders of Central Africa. When the WHO declares a public health emergency of international concern, or a PHIC, they're essentially pulling the global fire alarm. It is their absolute highest level of alert. It's not just a label, right? It's a hard legal and operational trigger. It signals an immediate, desperate need for a coordinated international response. We're talking mobilized emergency funding, worldwide border surveillance protocols activated, and a massive glaring signal to every health ministry on Earth that what's happening right now in Eastern Congo demands their absolute attention no matter how far away they might be geographically.
To really grasp the sheer magnitude of this threat, just look at the company this outbreak keeps. The WHO used this exact same emergency designation for the COVID-19 pandemic back in January 2020. They used it for H1N1 in 2009 and Zika in 2016. By putting this current Ebola outbreak in that exact same top-tier category, health officials are telling us point-blank the potential for international disruption here is incredibly high. But to understand why this specific outbreak is causing so much panic, we really need to look at the virus itself.
So here is the crucial point. Unlike recent Ebola outbreaks that the world actually successfully managed, we are now facing the rare Bundibugyo strain. Originating in eastern DRC's Ituri province, this variant changes the containment calculus entirely. Why? Because right now there is absolutely no approved vaccine and no approved treatment for it. None. That single reality, no vaccine, no treatment, is what separates this crisis from the Ebola emergencies we've seen over the last few years. It completely strips away our most effective modern medical defenses, leaving public health workers incredibly vulnerable.
Think back to the devastating 2018 to 2020 Ebola outbreak in eastern Congo that tragically killed nearly 2,300 people. That involved the Zaire strain. But for that Zaire strain, we actually had 2 approved vaccines. One of them, which they used in that specific response, achieved roughly 100% efficacy in ring vaccination campaigns. They literally built an immunological firewall around the virus, vaccinating contacts and then the contacts of those contacts. Grueling work? Sure, but it stopped the virus dead in its tracks. But for the Bundibugyo strain we're facing today, we've only got an experimental candidate. It's shown maybe 50% efficacy in monkeys, and get this, it hasn't even been tested in human patients yet. We have zero pharmaceutical preparedness for humans right now. Absolutely zero.
Because we don't have that immunological firewall to deploy, health workers are forced to fall back on grueling pre-vaccine era tools. We're talking rigorous contact tracing, strict patient isolation, heavy reliance on personal protective equipment, and intense community engagement. Now, don't get me wrong, these tools can work, but they are extraordinarily difficult to deploy effectively, especially right now. The Ituri province is currently an active armed conflict zone. Road access is incredibly limited. Plus, there's a deep historical mistrust of health authorities, so you're dealing with a local population that's been repeatedly traumatized by both disease and violence. Trying to execute perfect contact tracing in a literal war zone without a vaccine? It's a monumental, almost impossible task.
And honestly, the margin for error here is essentially zero, which brings us to a frankly terrifying number, 50%. That number represents the absolute lethality of this specific strain. Without any specific treatments available, Ebola Bundibugyo kills half of the people it infects. Let that sink in for a second.
To truly grasp how scary a 50% fatality rate is, let's put it into perspective. Seasonal influenza, that kills approximately 0.1% of those infected. The COVID-19 pandemic, which completely shut down the globe and literally altered modern history, had an overall fatality rate of roughly 1 to 2% in most populations. Ebola Bundibugyo sits at an astronomical 50%. So while absolute case numbers aren't at pandemic scale yet, we're currently looking at 87 confirmed deaths and hundreds of suspected cases, the sheer characteristics of this pathogen are what have epidemiologists deeply terrified. It's highly lethal, and worse, it's moving.
And that movement is exactly what escalated this from a regional tragedy straight to a global emergency. The situation shifted fundamentally when a suspected case crossed the extremely porous and very busy border into Uganda. That means the virus has officially left the initial outbreak zone in the Ituri province. The contact network is no longer just localized, it is international. Suddenly, every single country that shares a border with Uganda or has connections through Kampala's Entebbe airport has been pulled right into the epidemiological equation.
But the geography of this outbreak gets even more dangerous. Health authorities have confirmed a massive regional risk because cases linked to this outbreak have now officially reached Kinshasa. Now, Kinshasa is the capital of the DRC. It's a dense, bustling urban center of 17 million people. We're talking one of Africa's absolute largest cities. When a highly lethal virus, again with no vaccine, leaves isolated rural areas and enters a megacity of that size, the potential for explosive, uncontrolled transmission just skyrockets.
And you might be wondering, why does a single case in Kinshasa matter to you, wherever you happen to be watching this explainer right now? Well, because Kinshasa isn't just a large city, it's a major global hub. It's got direct international flights to Paris, to Brussels, to Dubai, Nairobi, and beyond. This is the exact nightmare scenario that keeps public health officials awake at night. An untreatable, vaccineless Ebola strain establishing a foothold in a major urban center that has direct international air links. The virus is quite literally just one plane ride away from entering entirely new continents.
So, how exactly did we get to this precarious precipice? We have to look at the timeline, specifically the severe issue of late detection. Health officials actually believe the very first case likely emerged in late April. However, the outbreak wasn't officially reported until mid-May. That means this virus had a massive 3-week head start to spread completely undetected. For 3 full weeks, the international health system didn't even know this outbreak existed. And during those 3 blind weeks, the virus was quietly and efficiently moving through highly vulnerable environments. It was spreading through bustling local markets, it was moving through regional hospitals that completely lacked adequate personal protective equipment, and devastatingly, it was spreading through traditional burial ceremonies. Now, these are known to be among the absolute highest risk transmission events because the Ebola virus remains highly infectious even after the host has died. This undetected spread drastically compounded the absolute urgency of the current situation, giving the virus deep, deep roots before anyone even started looking for it.
Complicating this incredibly urgent, on-the-ground reality is our current distracted global environment. The WHO teams that would normally deploy rapidly to eastern Congo are currently working with budgets and logistics that have been partially redirected. Global health financing institutions are managing severely competing emergency demands right now. International attention and resources are heavily focused on geopolitical crises, like the Iran war, Moscow drones, and major summits in Beijing. So we're looking at a situation where the international community is being asked to respond to a burning, highly lethal pathogen in the Ituri province, but global attention and logistical support are stretched dangerously thin.
The WHO has declared its highest alert. We know the tools available are incredibly limited, largely restricted to pre-vaccine methods in a very complex conflict zone. So I want to leave you with this final, critical thought to ponder. The window for containment is always narrowest in the very first weeks of an outbreak, especially before it takes hold in urban centers with international connections. As this highly lethal vaccineless pathogen spreads toward international airports while the rest of the world looks the other way, are we paying enough attention before that narrow window of containment slams shut entirely? Thanks for joining this explainer.